to Dr. Blue.
Thank you so much. I appreciate that. All right, well, let me go ahead and share my screen and we will get started. I appreciate all those kind words, so I will say that. All right. So, you guys can see my screen, right, Valerie?
Yes, we could see.
All right. So, basically, today I wanted to talk about the cellular therapy. So, one of the things that is really in the news, one of the things that you'll hear about at all the doctor's visits and any website or anything that you might Google or chat GPT is these things called cellular therapies, CAR T, bispecifics. So I wanted to not only just talk about those treatment options, but I wanted to talk about how they relate to us as a community, especially, like I said, during Black History Month. I do have some disclosures, but I wanted to kind of just keep going. Okay, so the big thing about multiple myeloma, for those who may be unfamiliar, is that, which really is similar to Joan's story, is that it kind of progresses over years, right? And so there's always this period of the cancer's up and then it's down and then it's up and then it's down. For those of us that are old enough to remember, we used to play with these things called yo-yos. The kids these days don't know what that is, but back, I hate that. I sound old, Jesus, when I say that, but back in my day, we had these yo-yos, and that was hours of fun just watching that thing go up and down. But unfortunately, that's what also happens with the multiple myeloma is the cancer's up and it's down. God knows we hope that it's years in between when it goes up and goes down, but sometimes it's just not that fortunate. And that's really the big problem why this isn't curable, because even though they get it down, here it come again. You know what I mean? Even if it takes several years, it just comes right back. So I just wanted to just let people know we working on it. We just not there yet. Okay. And so one of the things that happens is that, again, as Valerie mentioned, there's a lot of different medications out there. But the problem is that after you've been exposed to the immunomodulatory medications like the Revlimid and the Pomalyst, or after you've been exposed to the proteasome inhibitor medications such as the Velcades and the Kyprolis, or if you've been exposed to the CD38 monoclonal antibodies such as the daratumumab or the isatuximab, after that, what we call the big three, the chances of any other medicines working goes down a lot. And you can see that it's really only about a third, right? So after you've seen those medicines, which are the mainstay of this disease, then any other medicine has about a one-third chance of working. So if you tell somebody, say, hey, one out of every three people this going to work for, or really if I flip that, two out of every three people this ain't going to work for, then it's like, all right, we need to do something better, right? And that's really what we decided to do. And that's where CAR T came in, because we was like, look, all the traditional kind of chemotherapy medications and all the stuff that we had currently available, it's not necessarily working for people who have seen some of those what they call big three. And so then that's when CAR T came out, the first one that was approved. You'll see the word Abecma, that this has been about 5 years now. And basically what happened is that we know that CAR T was able to use the body's immune system to be able to fight off cancer. Okay. And that's really an exciting thing because it's a natural thing, right? Like we take your own cells and then we teach those cells to be able to fight off your cancer. And you can see that, again, when this was first approved 5 years ago, that it was working in about 75% of people. So that's three out of every four. So compared to what was already available, you can see that CAR T was kind of coming through like, boom, this was a big deal. Okay. But like everything else, we had to kind of do research studies that basically kind of proved what we thought, right? So, like me as the doctor, I can't just go in and say, oh, I think this is going to work. I have to prove that to people. Does that make sense? So, we do that through clinical trials and through research. And that's how we were able to find out and actually get it approved by the government to say, hey, insurance companies, you guys need to be paying for this, because once you pay for this, your person's cancer is going to be really, really, really well taken care of. And that's going to help out in the long term. But not all the time, are you just going to have one player? There came a second CAR T, meaning that you can't just have McDonald's, you got to have McDonald's and Burger King, or you can't just have Popeyes, you got to have Popeyes and Churches. You know what I mean? So there always has to be multiple options, right? And so what came along, pretty much roughly like a year or so later after that first one got approved, was a second CAR T. All right. Now, both of these CAR Ts, the way that they teach the cancer, teach your immune system to fight off the cancer, is they look for something called BCMA. So they both have the same target, okay? And they saw that when they did those special clinical trials or that research that I was just talking about, that this CAR T was working in like 95, 97% of people. So overwhelmingly, majority of the people who was getting these medicines, it was working for, which again is way different than somebody saying only 1/3 of people. So whether it's CAR T number one or CAR T number two, compared to anything else that was available, these new way of treating cancer were really doing a fantastic job. Okay. And so again, they did different studies that basically proved that that point was true. Okay. Now, for people who may be unfamiliar, think about CAR T as multiple different steps. The first step is that you got to come see a doctor like me who's a multiple myeloma specialist or a CAR T specialist. And then what we'll say is, yes, we think CAR T is right for you. And then after that, they have to collect that immune system cells, right? And the word that we use for that is called apheresis. That's when we take your own blood cells and we remove them by drawing blood, okay? After that, then we basically can manufacture those cells, or basically take that blood that we just took out of your body and we teach them to fight off cancer using that BCMA, all right? After those cells are now ready, which it roughly takes about a month, okay? After those cells are ready, then now they're ready to be infused or put back into you, all right? The issue is that I can't take those cells straight from the lab and just put them back into your body. So prior to us administering the CAR T, there's a couple of days of chemotherapy called lymphodepletion. And so you get a couple days of chemo, and then basically we put those cells back into you. All right. Most of the time, you have to be either in the hospital or around the hospital for somewhere between 3 to 4 weeks. You know what I mean? Because we just did this new procedure. We need to make sure that you're close by just in case you're having any issues. Okay. But that's kind of like how things go. You see the doctor, they collect the cells, they teach the cells how to fight off cancer. Couple days of chemo once those cells are ready, and then they put those cells back into you. So this was just kind of a side by side of the two CAR T options that are available. So you might hear some people say they had the what they call a Abecma CAR T, or if you hear somebody say they had the Carvicti CAR T, now you know what they're talking about because those are the two CAR Ts that are currently available. There is a new CAR T that will probably be out sometime soon, but it uses a different target other than that BCMA. It uses something called GPRC5D. All right, now this is not approved from the government yet. It's still in that research phase. Okay, but again, it's coming out and it will be available soon. Now, those are the good things about CAR T. And again, just like everything in life, there has to be some pluses and minuses. For every days that you get sunshine, you're going to have some rain. You're going to have a storm. You know what I mean? So just because CAR T do a good job, there are some side effects, and those things probably need to be discussed. The number one side effect when it comes to CAR T is what they call CRS, or cytokine release syndrome. You say, what the heck is that, Dr. Blue? All these letters. Basically, what happens with because we are activating your immune system, think about CAR T is basically like well, I'm about to say the key that turned the car on, but we don't really even need keys no more. Technology, you just press a button and you just get in your car. Your keys never leave your purse or your pocket. But for the old, I'm gonna say the old folks of us, but those of us who got a little bit of gray hair, we used to have to turn the key and that would turn on the car. Well, think about that's what CAR T is doing. It's turning on your immune system so it can fight that cancer. So what happens when you turn on the immune system, people get fevers, chills, they get fast heart rate, low blood pressure, okay? Because the immune system is being activated trying to kill that cancer. Now, the second thing that happens, or potentially could happen, is what they call neurotoxicity. And really what that means is that the whatever we believe, all right, so however you believe humans were made with a natural protection. So what that means is that God gave me a thick skull because he know that Dr. Blue might trip and fall and bust his head. God gave me nice lungs so I could breathe in oxygen, but I also have a rib cage that's real strong that protects my lungs. Well, because medicines and things that you could put in your body can be toxic, there's a natural barrier that everybody has that prevents things from getting to their brain. Well, the CAR T unfortunately passes through that barrier, what they call the blood brain barrier, which is a natural protection, and it gets in there and sometimes can cause some confusion. And those things can sometimes be very different than what people are used to. Your husband or your wife might walk in the room, you say, "You look pretty. Who are you?" And sometimes that can be quite confusing. Or somebody say, "What year is it?" And you still think it's 1975 and you wearing bell bottoms. Okay. So just know that that can happen. And that's a much different side effect than any of the other like treatments that are currently available for multiple myeloma. So just know that the doctors will basically be assessing you to see, hey, do you have that CRS? So are you having a fever? Are you having a low blood pressure? Are you breathing okay? All right. And the doctors have different like grades or different steps or seriousness that they can do and things that they can do based off of how serious it is. Okay. The same thing for that neurotoxicity. So that means you walk in, don't get upset with the doctors because they're going to be asking you, what year is it? What city you in? What state you in? Now, I'm going to tell you, sometimes people say, Dr. Blue, I just answered that question to the person. I'm like, look, I got to ask you these questions because I'm trying to make sure that you know what's happening. Okay. So just know that they're not trying to come at you a certain way. They're not trying to like insult you or nothing. This is just what it is. All right. They just trying to make sure you're not having no problems. Okay. So just know sometimes it could be so serious that sometimes people be having seizures and sometimes it does get real serious. But the thing is that the doctors are really well trained, and that's why it's important to go to a place that, does this a lot so that we can either prevent it or if we see it, take care of it. And just know there are medicines that can help take care of this stuff, okay? So just know that I'm telling you about this stuff just so you're aware of it and you've heard it before, but don't let it scare you to the point where you're like, I don't know about this, Dr. Blue. It's like, hey, we can take care of it, okay? So just know if the best way to help with these things is likely prevention, meaning like to identify it before it get to the point where you're having some of these problems. And if you go to a place that does this a lot, we're able to actually identify it. Okay. Now, the other thing that happens is infections. Okay. Now, infections can happen with some of the other myeloma treatments. So those first two were kind of like almost exclusively with like the CAR T and the bispecifics and those kind of things. But infections are gonna be a big issue regardless of what type of treatment you're on. Even if you're even not on treatment, just by having myeloma itself, your immune system is gonna be lower than everybody else. So just know that that's always gonna be a case. The other thing that can happen with CAR T is that sometimes people can have low blood. Okay. Now, the low blood could either be your white blood cells, which is your immune system, which we just talked about, or it could be your red blood cells, and you may need a blood transfusion. You may have never had a blood transfusion before, but it's possible that with CAR T, you may need a blood transfusion. The thing is that it recovers, meaning that you can see how it'll go down, but then it just come right back. Okay. And during the part that is down, then that's when you may need the transfusions. Okay, so just know that that's definitely possible. Now, that's CAR T. So think about CAR T as your own blood, your own immune system fighting off your cancer. Well, we also have what they call these bispecific T cell engagers or BiTEs. don't nobody really want to say bispecific T cell engagers all the time. So we have to shorten it and just use the word bites. Okay. So just know if you hear the word bites, it ain't talking about lunch or dinner or something that you just ate. It's talking about this bispecific T cell engager. Now, these are not your own immune system cells. These are ones that we get from the pharmacy. Okay. And so, again, they also can target that same BCMA that we just talked about. All right. The first one that was approved has been about 4 years now, what they call teclistamab. All right. You might hear also people use the word Tecvayli. All right. And these also have that same kind of like issues of that CRS and that neurotoxicity. Okay. Now, again, when they tested these things, because again, just because we think these things are going to work, we have to prove it. When they saw how well these things work, you can see that they were working in an overwhelming majority of the people. So you can see that it was like 60, 70% of the people who were receiving these therapies were actually getting a response. Okay. People, again, we're getting those same toxicities, the CRS, but again, we can treat those things. But just know that people was getting them when we had to research these things, okay? Now, the difference is that instead of us collecting the cells, having to train the cells, having to give you some chemo, this is something that if you come and see me, what's today? Thursday? By next Thursday, we can get this going. Because again, this doesn't come from you, this comes from the pharmacy. Okay. What happens is that the biggest difference is that you have to do what they call a ramp up, meaning that I can't give you the first dose as the big dose. I have to give you a small and then a medium and then a large dose. Okay. And so that's just making sure that number one, your body can handle it. And number two, that we're not seeing those cytokine release syndrome or those toxicities that I just talked to you about. Okay. So this is definitely a quicker thing that can happen. So if your cancer is on fire, this might be some of the water that your doctor might use to put out that fire because it can happen within a matter of days. Just know that it's a lot of different ones out there that might target that BCMA, but there's other ones out there that have different targets. Okay, so if you hear somebody who is on a medication called talquetamab, yes, it's still a bite, but it does not use that BCMA. Okay, and so just know that there's other ones out there that are available. Now, if we look at them side by side, my mom always told me you're not supposed to compare apples and oranges. They just different, okay? There's advantages to one, disadvantages to the other, but just know that they both work, okay? From a just a remembering standpoint, the CAR T is very personalized, meaning that you can't take your CAR T and give it to somebody else because it's your own blood, it's your own immune system, right? The thing about CAR T also is that it's a one and done. You do the CAR T once, and then those cells just get in there and they just do their thing. So you don't have to continuously be on pills and injections and those kind of things. Okay. So that's definitely a big positive. However, with the CAR T, I can't tell you on a Thursday you need CAR T and we doing it by next Thursday. It takes time. And if your cancer's running 100 miles an hour, sometimes we just don't have that time. Now, with the bispecifics or those bites, again, it's quicker. But again, once you get this treatment, it's continuous treatment, meaning that, like, if you're going on Fridays for your injection, every Friday you're going to be getting a shot, or maybe they'll do it every other Friday, right? So some of them are every other week, some of them are weekly, but just know it's not a one time thing, it's a continuous. All right. So the biggest thing is that you find out what's right for you. Just because you ask somebody, they might do something different and different strokes for different folks. Now, let's talk about us for a second. All right. That's kind of just the general multiple myeloma thing. So, when we look at some of the differences when it comes to people in the black community, what we notice is that when we get that CRS or that cytokine release syndrome, unfortunately, we get that a little bit more often than other folks. Okay. So, that means I don't know if that's due to stress, because Lord knows this thing be stressing us, and we got the cancer stressing us, we got the family stressing us, we got money stress. We got a lot of different stressors. And so we don't know the reason why, but we know that, like, the having those fevers and chills and the low blood pressure, all the things that can happen, sometimes we do see that a little bit more. All right. The other thing that we see is that they did a lot of these studies and research, and they say that like of the people who actually able to get CAR T, only about 17% actually got what they needed. Does that make sense? So like that's saying, hey, it's cold outside. Everybody need a jacket, but only 17% of the people actually getting jacket and the rest of the people staying cold. Like that, like you would never do nothing like that. You know what I mean? Like, and that's because it's available. The government has approved this. Your insurance should approve these things. But unfortunately, we just not getting access to these things, and that's a real big deal. The other thing is, remember us talking about that research that I was telling you about, how, these CAR T things had to be proven, right? So black folks make up about 20% of the myeloma. So that means one in five, okay? But it was only in one of the studies, 7% black folks, and the other study, about 3% black folks. So we wasn't really in those trials that got these things approved, okay? So um, again, that's a whole nother topic. I don't know how much time we got today, but just know that you know we need to be involved in these things because these things are the future. Okay. Also, like so, even when it's not part of a clinical trial, they do what they call this real world information. They saw that even once CAR T got approved, you would think that we would be kind of like, because again, we weren't involved in the clinical trials or the research part. Well, when it got approved, what they saw was that the gap was actually widening, meaning that like once it got approved, we was not the first ones in line getting this thing. And so that means that if we was already behind, other folks was getting this, and then that gap just got bigger and bigger and bigger because unfortunately we just fell behind. Okay. And so this is real life, and this is what's happening for our community. Now, the good thing about it is that we looked at this and we tried to figure out, well, does it work differently? We might have a little bit different in like who gets it or some of the complications, but we saw that there was no big differences in like how well it works, meaning that it works the same, really good for white folks. It works the same, really good for black folks. So we didn't see any difference on like how well it works, which I think is a good thing. That just means we got to get it though. You know what I mean? And so the biggest thing, like I said, is just that toxicity difference where that CRS can happen in, again, not 100%, but 97% is, God knows, is pretty close. So majority of the folks who do get the, especially from the black folks who get the CAR T, do notice that they do have some differences. Okay. Now, the thing I know about this webinar is that it's probably people from all over the country or maybe even all over the world. So just know that CAR T may not be available where you are. Okay. 34% of the states in America don't even have CAR T or the bispecific clinical trials like in their states. Okay. So this little green map kind of shows like some of the breakdown of where some of those centers are. And you can see that, like, if you live, in the South, if you live in the East and Northeast, but like, for example, if you take Alabama, you know, it's as long as you and when that one spot, you have to drive so far. You know what I mean? If you are in, some of these other states, it just, yeah, they might have one, but it might be so far from where you live. You know what I mean? So just know that again, these things are new. Right? We talking about just a couple of years. So there'll be more and more of these green dots available. But right now, if you live in certain areas, it may be a travel issue. Okay. And so I always have to end my talks by just talking about this study because I think this is super important. Because prior to us even getting multiple myeloma, I don't know if you remember us talking about that, people have that MGUS or that smoldering myeloma. The one thing that we want to do is find out how we can screen people for it, meaning that like you reach a certain age, you get a mammogram. Well, if you reach a certain age, you can get tested for multiple myeloma as a part of a study called the PROMISE study. Okay. What will happen is that you go to the promisestudy.org, which is the website, you sign up, you receive a little kit in the mail, and then you schedule your blood draw. Okay. You get some results that say either you do or do not, but we can get it checked before you have some of the damage that can be done prior to actually having the active disease. You just got to be 30 and be of African descent. So we all know a 30-year-old African American, everybody on this call. So that means you know somebody who can get checked. Okay? If you yourself already have the disease, then talk to your family. Okay? Because again, we're trying to get people early detection and awareness about this disease. Now, the one thing I do just want to say is that if you get the test results that come back, the next thing that you got to do is actually do something about it. Okay. So this is not a fear thing. This is something that is just being proactive in your own healthcare. The good thing about this test that even when it's negative, people can rescreen or test again after 3 years to just make sure that if it was negative when you was 30 or 40, that it's still negative a few years later. So I appreciate everybody's time today. Thank you so much for the invitation, Valerie. And like I said, I'm happy to talk or do whatever people need to do to kind of make sure that we take care of our people when it comes to this disease. So thank you.
Awesome. Dr. Blue, thank you for that presentation. I learned a lot in that. What we're going to do now, I give each doctor after their presentation an opportunity for us to do just a quick Q&A session here. So I see we had one question put in the box there, but if you do have a question, feel free to drop it in the chat. We can get it addressed. You can raise your hand, utilize the little raise hand feature under React on the bottom of your screen, or if you're on a tablet there, just use that raise hand feature. So Dr. Blue, you mentioned that access, we often think about the access of it, and a lot of times it's just not available. What are you seeing, or what are your thoughts on when it is available, but patients are still, not getting it? I know a lot of times it requires a referral to academic center. And a lot of times that pathway to getting patients there, it's very complex. But what are you seeing? Where are we losing? Is it the referral? Is it the evaluation? The timing of it, just eligibility? What are some things that you're seeing when it comes to access, other than it just not being available in a particular place?
Yeah, I think it's tough, right? Like, I think it's two things. I think number one, this is very different than anything else. Like, it's one thing if somebody says, "Hey, you have cancer. I need you to go to the doctor every Friday and get an injection." Like, that makes sense. You're like, "All right, I'm getting some medicines. They're going to take care of it, or I need you to take these pills." But for you to have to relocate your whole life and you need a caregiver to be in a whole new city, sometimes that's tough, right? And so I think that that's some of the barriers that we see is that, and we didn't get too much into this, but just so folks know that as a community, we get diagnosed with this disease younger than everyone else. So, blacks and also Hispanics, we get diagnosed at the younger ages. So if you're younger, that means you might be still working. So that means you having to tell your job, which your job for most people is how they get their insurance. So you have to tell them, say, "Hey, I can't work for a month." Sometimes that creates a problem. Your job might say, "Look, you still want to work here, you need to show up." Right. And so it's a big commitment, right? And so I think that's a big barrier. And so that's why I'm hoping that we can get um just ways for us to kind of get more of those little green dots on the screen so that, if you had to travel, 15 minutes to get your car tea, you might still be able to, work remotely, or they might be able to figure something out with you than to be like, "Hey, I live 4 hours away. I got to go all the way here." And it just creates a whole problem.
Yeah, yeah. Thank you for that.
Yeah.
And just know that if that is something that you are considering, you don't have to have one dedicated care partner. If you have several, it takes a village. We always say that. So you can have several people from your village that's helping you through that process there. So hopefully that is one way to kind of break that barrier of, I have to have a dedicated care partner. So, yeah. Tanya has her hand raised there. What's your question, Tanya?
Hi, Valerie and Dr. Blue. I'm very new here. I was diagnosed with smoldering multiple myeloma, and I don't have any of the crabs or any of that. It's just my blood work's off, and I have my kappa. I have IgG kappa high, and my MGUS, not MGUS, M spikes is a little high. And they're trying to figure out whether to treat it or whether they're not treated. To me, it's like high, high. And what is it called? I guess when you have the thickness of the blood, it's called something. So I'm kind of there trying to just figure out whether to treat it, if they treat it, how to treat it. They're saying that if it goes to active myeloma, there's a new study coming out that I could possibly be a part of this for a relapse and refractory patients, or is the I guess the big the all the four, the V, all that stuff. So I'm just kind of I just don't know what to do.
Yeah.
Just
Yeah, so Tanya, I'll be honest with you. Listen to your heart. You know what I mean? If you're a praying woman, pray on it. You know what I
oh
mean?
yes,
Because
yes.
because the issue is that just because something is available doesn't mean you got to do something about it, right? Like, they see that the blood is off. Does that mean you need to do something about it? Does not necessarily. So, for example, let's just say it's February, Black History Month of 2026. If
Mm-hmm.
they check your blood in a couple months and it hasn't changed, and now we February Black History Month of 2027 and everything the exact same, then it's like, hey, this cancer might be moving so slow that maybe I don't need to treat it right now, right? You might just say, hey, things are okay. But if it's February and they see what your numbers is at, and then they check it again in April and the numbers a little bit higher. They check it again this summer and then it's like, all right, this thing might be moving. So then you can say,
Mm-hmm.
all right, man, well, if it's already moving, then maybe let me go ahead and do something about it. You know what I mean? So just kind of see what works for you. And then again, whenever you start something, I talked about the good stuff, but I also brought up these things got side effects, right? Ain't no medicine in the world. Tylenol got side effects. Ibuprofen got
Mm-hmm.
side effects. So you
Mm-hmm.
got to think about that as well. You know what I mean? Where you at with your work? Where you at in life? You know what I mean? Depending on who else you got in your family, you might say, hey, I have some people who tell me sometimes, Dr. Blue, I'm ready for treatment, but my kid's about to graduate high school right now, so let me get them through that, or they about to do that. You know what I mean? So all those things play a factor because a lot of times once you get on the myeloma treatment train, a lot of
Mm-hmm.
times you don't come off. Okay, you
Oh
stay on
wow.
some type of treatment typically until it stops working. You know what I mean? And so just think about those kind of things. But again, there's no person that could tell you what's right for you. But though that's why it's good to kind of talk it over with your doctor. Hopefully, your doctor is a myeloma expert, and so it's somebody who you can kind of get like a second opinion if your doctor's not a myeloma expert, and just kind of talk through those things and have a discussion.
Okay, because like my um Kappa IgG numbers are like what was it? I think 6,000.
Hmm.
So that's pretty high.
Yeah.
And my M spike is like it's like a 4,
Sure.
but
But
everything else is fine.
and that's what I'm saying. But again, if it's 6,000 in January, I mean in February, and it's still 6,000 in a couple months, or however frequently they're checking you, then you say, hey, maybe it's not moving that fast. So at some point you're gonna likely need to be treated, right? Like that's
Hmm.
what's happening. And so the
Yes.
question for you that you and your doctor need to answer is that time now? Right. And so there's a lot of different factors that go into that, but that's why you want to try to make sure that you and your doctor tell them don't rush you out the office chair. You know what I mean? You sit down there and y'all talk about it. You know what I mean? And if they
Okay.
don't finish that time, you say, all right, well, let's talk. Call me on the phone or set up a virtual visit. You know what I mean? It's different
Hmm.
ways to kind of interact with your doctor to make sure that y'all really getting all your questions answered.
Okay. Thank you so much.
Yeah, no problem.
Thanks for that question, Tanya. So to piggyback on that, Dr. Blue, so we just like Tanya is, she's trying to make that decision on, start treatment, not start treatment. These decisions can be tough too when we just talked about it. You don't have that care partner. It's part of that whole decision-making process. What are some of the other concerns or barriers that you hear from patients when it comes to CAR T and bispecific therapy? And how can you, as a doctor, how can you kind of guide them through that and support them through that process?
Yeah, yeah. It's unfortunately it's one of those things that happens. One of the things that I know a lot happens a lot is people when they come here, they say, well, where I'm gonna stay. I don't know nobody in this city, right?
Mhm.
I'm coming all the way from, my little circle where I know my people, and now I'm coming to the city. Where I'm gonna stay? Who's gonna help me pay for food? The good thing is that it's a lot of resources and stuff that because, and I'm sure people on this call might know this. Just because you got cancer, don't mean that the mortgage stop or the rent ain't due. You know what I'm
Mm,
saying? So the bills keep coming, even though you trying to do what you got to do that's best for your life and your health. So the good thing is that it's a lot of resources that can help you kind of offset the cost of those things so that you can focus on your cancer.
absolutely. Absolutely. All right. I'll go to a couple that we have here. We got time for a couple more questions and then we'll move to our next segment. But we're still going to have some more Q&A as we go. So just keep dropping them in the box there. So this participant asks, is SBRT radiation the best way to deal with rib lesion that is getting larger? Any other options other than radiation?
Yeah, good question. So typically, the way radiation typically comes into play when it comes to multiple myeloma is for pain control. So all the medicines that Tanya was talking about, the Darzalex, Revlimid, all those different medicines and pills and shots, even the CAR T, those bispecifics, all these medicines, they work everywhere. Meaning that like it kind of really works at all the different places. The problem is that just because you get an injection on Thursday, don't mean it's going to start to kill all your cancer by Friday. None of these medicines work right away. So what happens is let's just say that rib or whatever problem in your back or wherever is hurting you. What as a doctor, I don't want you to just be laying around in pain for the all the time while these medicines are working. So I might say, hey, let's try to do radiation like to kind of like at least help with the pain because typically radiation works very quickly with at least getting the pain under control so that while these other medicines are doing their thing, at least you're not suffering and you down in a whole bunch of pain pills. So that's really where radiation comes in, just for that specific purpose. And so the main thing is what does the systemic therapy look like, or what does the total treatment look like? Because that's really what's going to work everywhere. Because radiation is like a beam; it's only going to narrow hit that one spot. So if it's on your left side, another one could pop up on the right side. But we just can't keep boom, 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 and just hitting all those different places. That's why you need medicines that work all over.
Absolutely. Thank you for that. Um, I see a couple of questions in here. We're going to answer these. We'll get you a direct answer as far as the promise study and the locations. I know the one you referenced, Dr. Blue, that's at Dana-Farber, correct? I know.
No, so it's actually national. So Dana-Farber, who started it, but pretty much there's several academic centers across the country that have partnered with Dana-Farber to make that happen. So I know Moffitt, John Hopkins, several of the big centers across the country. But yeah, if you go to promisestudy.org, there's a website on there, there's a phone number on there, there's an email on there. So because some people, they don't want to do it through the internet, but there's a phone number that you could call. You know what I mean? So or an email as well.
Absolutely. And then HealthTree has patient navigators that can help you through the process of finding that as well. And we'll send info in the follow-up discussion there. So this will be the last one, and then we'll go to our next speeches. It says, how do doctors determine who is eligible for a CAR T? I thought that was a good question there.
Yeah, it's complicated if I'm being honest with you. The main thing that I'll say is that there's no age cutoff. So people sometimes say, "Oh, they think I'm too old." We all know people who 60 and they look 80. And we all know people who 80 and they look 60. You know what I mean? So really what happens is that it depends on how well you have been keeping up with your body and your life. So, the biggest thing that I tell people who like Tanya, who are not on active treatment yet, like they say, well, what can I do? I say the best thing that you can do is to be in the best shape of your life each day that you live. Because you only as old today as you are today. Each day that we live, we're a little bit older. You know what I mean? And Father Time is undefeated. You know what I'm saying? And so you just have to make sure that even if it takes this disease, I don't know, 5, 10 years to turn active. What, 5, 10 years from now, you want to still be like, all right, I'm looking good, I'm ready, you know what I'm saying? I'm moving, not like, they told me I had this pre-cancer. I know they, I just started smoking and drinking and doing all this, and then you showing up in a wheelchair, and I'm like, hey, I, I would hurt you if I gave you medicines right now. And I unfortunately have, who knows, 10 years, we might even have a cure for this thing. So I might say, hey, I got a cure for this, but You let yourself go. I would hurt you and not help you. And as a doctor, my number one goal is to help you. So just I would say that's probably the biggest thing.
Awesome. Thank you. Thank you.
Yeah.
And just to confirm, my team, is Dr. Biltabo coming in yet?
I'm here.
You're here? Okay.
Yeah.
Hey Eden, how you
Welcome,
doing?
Hi, Brandon.
welcome, Dr.
That was
Biltabo.
awesome.
Listen, you guys are gonna if you thought this was good, I'm telling you, Eden is fantastic. She is amazing. So I'm excited too.
Don't set the expectation that high. I loved your presentation. I was wondering if mine is going to be
It'll be
a
even
little
better.
too complicated. Let's see. But I'll try to simplify it as much as I can. All right, let me get my PowerPoint here. Um,
And just as Dr. Biltabo is loading her slides there, she's going to share a little bit, with some of the data and when it comes to access and disparities and outcomes. So that's what we can expect from Dr. Biltabo today.
All right, and I don't know if I haven't shared my video yet. Let me get that started. All right, thank you so much for inviting me. It's always exciting to have a patient-facing presentation because it really helps the patients, and I enjoy just talking to patients in general. So I was excited to have this opportunity, and thank you, Valerie, for this invitation. All right, I'm going. Okay. So we've been talking about access. I believe access, when I think about access in general, I think of this conceptual framework. It has to be timely, it has to be affordable, has to be high quality, not wasteful, physical proximity to where the patient lives at, and patient-centered always. And if we have all that combined, we would have the best possible health outcome. Um, I'm going to start with some epidemiology here. We all know and we have heard so far that multiple myeloma is 2 to 3 times more common in African Americans or in general Black population. And when it comes to the mortality, unfortunately, still Black patients are dying more from multiple myeloma. So this is really our problem, and we really need to understand what's going on and how can we help ourselves? How can we help the patients that will be diagnosed with multiple myeloma after us? And um, just get what is available out there and how can we help ourselves in getting the best treatment as well. So I couldn't agree more with Brandon. We have to all enroll in every clinical trial, including all the cancerous phases, MGUS, smoldering multiple myeloma, everything that's available. One, we will be able to get the base care through that, and also we will be able to help the person behind us in improving understanding of the diagnosis and of what works for our patient population. So this was a study that was done a long time ago in 2009 that proved that MGUS actually does precede multiple myeloma. How they did that was they looked at a cancer screening registry called PLCO, and they identified 71 subjects between 55 and 74 years old. And they went back and looked at their blood samples in the past before the diagnosis of multiple myeloma was made. And it looks like patients as far out as 8+ years had MGUS before they were diagnosed with multiple myeloma 8 years down the road, especially nowadays that we have some kind of intervention at different stages. It's really important to catch it at the precancer stage if possible. So this was one good discovery and an opportunity to intervene early. So I have already mentioned that there is racial disparity in multiple myeloma diagnosis and mortality, or how many patients die of myeloma. How about in MGUS, that monoclonal gammopathy of undetermined significance, the precancerous phase, that patients are still asymptomatic, nothing is wrong with them, but they had this blood work done and it's showing some excess protein in their blood, right? At that phase, do we have more MGUS in Black patients, or does the myeloma just pop out of nowhere, right? So this study looked at more than 12,000 patients with around 2,000 African Americans in it. They identified 365 patients with MGUS and 90 African Americans with MGUS. And what they found out is that prevalence of MGUS in African Americans was 3.7%, whereas in their white counterparts was 2.3%. And on this study, they made association. Now, this is not cause and effect, but the patients with MGUS, advanced age, male sex, increasing body mass index or obesity, and low socioeconomic status were associated with MGUS in these patients older than 50 years. And then they did similar study in patients between 10 and 49 years, looked at over 12,000 patients in the age range between 10 and 49. There were 4,000 African Americans, and prevalence of MGUS was even higher in African American patients in that younger age group. So it was 2.5 times higher than their white counterparts in the age group 30 to 39, and it was 6 times higher in African Americans in the age between 40 and 49 years. And in this young age group, MGUS prevalence was not associated with body mass index, socioeconomic status, or smoking status on the study when they adjusted for the different variables the patients had. So this makes you wonder, is this genetic? Do we inherit it? And several studies are out there throughout the years looking at familial clustering. What that means is you have a sister with multiple myeloma, now you have MGUS, or you have an aunt or uncle or parent or grandparent with MGUS or multiple myeloma, and that the cases tend to cluster within a family. So the Swedish study was able to prove that. And what else they noted on that study is that those patients in that familial cases, they were being diagnosed at an early age, as early as 54 years versus 67 years for the rest of the population. So they were thinking there is probably a genetic hereditary component that we inherit from our parents for multiple myeloma and MGUS. There was a similar study in Utah. They looked at 1,300 multiple myeloma patients and several of their first, second, and third degree relatives. And what they found out is that there was excess of multiple myeloma, prostate cancer, melanoma in all types of relatives of the patients with multiple myeloma. With this, there were some studies done in the European patient cohort or ancestry that identified right now that this 24 number has increased. More genetic mutations or alterations have been identified and were associated with multiple myeloma, or are believed to potentially cause multiple myeloma. And after this was identified using wide genome-wide association studies, are what these are called, using a lot of European ancestry databases, or tissue repositories. Other researchers from the US tried to look at the African American population and see if those genes are the main drivers, or if they had the same impact in causing multiple myeloma in the African American population here. It looks like when there is multiple myeloma, those genes are still expressed in the African American population, but their association, they called it, was modest. It wasn't the cause, or it didn't seem like those genes that are already identified were really reflected in the African American population. This is a very important finding. It reflects one, the importance of representation in the tissue banks, in this PROMISE study, for example. We just have to be able to participate. That way, we will understand more about our own genetic predisposition, because what might be causing cancer in a different kind of population might not be the same thing causing cancer here. So it's really important to take part in those precancerous studies, or even after having cancer, any kind of study makes sure that there's representation of the Black population, which helps us use that data in the Black population in the future. If I have African American patient coming to my clinic, I'll be referring to a study where there were enough amount of, African American patients on it to tell them this is what they did when they were exposed to this drug. Just how Dr. Blue was telling us, there was more CRS from the amount of patients that were in that clinical trial for CAR-T. We got that information because those African American patients were willing to take part. So if we are taking part on this genomic studies in CAR-T and other clinical trials, then there will be representation, and we can use that data safely to the next African American patient that we see in the clinic. So it's really important to take part into that study, that kind of study. This other study that was just reported in 2024 was looking at pathogenic germline variants in DNA repair gene. So we all have heard about BRCA, probably. That's one of the genetic predisposition for breast cancer. PALB2 is also another one that can predispose patients to pancreatic cancer or breast cancer. So this DNA repair genes, or genes that kind of control at um, the cell's brain level, or the cell's innermost operating system. Basically, when it gets altered, it predisposes patients to cancer, and we inherit those genes from our parents. So this study was able to identify that, this DNA repair genes, or those genes that really modify patients' risk of cancer, patients' risk of breast cancer, prostate cancer, pancreatic cancer, actually is also present in multiple myeloma. So they were able to take two different cohorts, two different patient population, and confirm that on both patient populations. This is from a COMPASS study, a different kind of study, and this is from their own clinic at Mount Sinai, from their own patients, myeloma patients, a gene. Basically, it's not the myeloma genes. These are their own genes that they inherited from their parents. Usually do it with a buccal swab to get those cells that we inherit from our parents, instead of the mutations that the cancer acquire by itself. So this, we are talking about the genes that we inherit from our parents here. And they were able to identify that up to 10% of patients with multiple myeloma, or 1 in 10, as it's presented on this picture right here, can have a gene that they inherited from their family that's causing the multiple myeloma. Now, this is a very important information, and it just solidifies the fact that yes, MGUS could be hereditary, myeloma could be hereditary. And not only that, but these patients that they inherit the myeloma gene from are diagnosed at an early age, just like how Dr. Blue was mentioning earlier. And beyond that, when stem cell transplant is given, those patients with those mutations tend to do the best, better than other myeloma patients who do not have that genetic mutation. Now, this is a very good information, but have we started testing for this yet? No, but we need more clinical trials, and participating in any clinical trial after the diagnosis will help us get there. This is another hereditary cancer registry where any of you could be a part of. You can enroll, register. They will ask you to do your buccal swab and send it, and they will taste it for any kind of hereditary cancer predisposition. They will be able to share the study results with you. But the only problem with this is that right now, breast cancer is the one cancer area that they're really actively tasting in. The problem is always money. We just need more money and more number of patients in each disease group. If there is enough amount of patients in myeloma, we can hopefully ask for more money from different funding sources and be able to taste it so we can get more data. So next time we have more evidence to present to insurance to say, we have this data, so we need to taste this patient. The advantage of getting the genetic screening right away is this BRCA gene, this other genes that we're talking about, they predispose patients not only to myeloma, but breast cancer, prostate cancer, pancreatic cancer, and these are cancers that we can do something about before the cancer actually emerges. So it will allow us to have an early intervention. And you can think of yourself as I am giving this talk of any family member that you know of with different cancers, right? If there is presence of other cancer in the family, and if there is diagnosis of myeloma, this study that I just presented put 50 years as a cutoff. If there is a diagnosis of myeloma before 50 years, it's more consistent with that hereditary component. Unfortunately, we cannot provide genetic testing outside of this trials, but please be a part whenever you get the opportunity. So we're talking about MGUS, but now we're also talking about just how Tanya was mentioning, we're talking about low-risk smoldering multiple myeloma and then high-risk smoldering multiple myeloma, and then the diagnosis of multiple myeloma itself. And it seems like we can do something for every stage right now. This is a study that came out last year from Sloan Kettering Group. It's called Nutrivention, looking at high fiber plant-based dietary intervention in multiple myeloma patients with higher BMI. They looked at 23 patients. They gave them high fiber plant-based diet for 12 weeks and they supervised their meals for 24 weeks. And this patients had improved quality of life and modifiable risk factors like BMI, gut microbiome. I'm not going to get in there, but that's also another reflection where patients would do good if they have a good diversity of bacteria in their gut. And in general, other monocyte subset cell counts that they looked at, there was an improvement. And I'm bringing it here because disease projection trajectory improved or was stable. When we say disease as MGUS from smoldering or smoldering from myeloma, that trajectory has improved with high fiber plant-based dietary intervention. Now, this is a small study, so it just gives us a hint that maybe dietary intervention, having a healthier BMI might help us, as we have already mentioned with some of the MGUS risk factors, increased BMI is one of the things that was attributed. So this is something to give us a clue, but there should be a bigger study. Hopefully, if you get one close to you, be a part and benefit from the study. The other one is Aquila. Aquila trial is looking at daratumumab for 3 years in high-risk smoldering multiple myeloma. They defined high-risk smoldering multiple myeloma in this study with bone marrow plasma cells of 10% or higher, and IgA subtype if the smoldering multiple myeloma is IgA instead of IgG or IgM. Or if there is, let's say, Tanya earlier told us her IgG was 6,000 If her IgM and IgA are lower than what they're supposed to be, that's called immunoparesis. So those patients with immunoparesis were also a part of this. The other thing is free light chain ratio. Sometimes the kappa is high, sometimes the lambda is high. If the kappa over lambda or the lambda over kappa is above 8, then that was considered high risk. And those patients with bone marrow plasma cells between 50 and 59 were also included on this study. And what they found out is that patients on daratumumab had lesser, around 20% lesser progression into multiple myeloma after following them prospectively for about 5 years. As you can see right here, 63% of patients who used daratumumab did not progress, whereas 40 point no, 63% did not progress, and only 40.8 remained in smoldering multiple myeloma among the patients who were just on active monitoring without any drug intervention. So daratumumab is now available for high-risk smoldering multiple myeloma patient. And if there are two things. Again, I agree with Dr. Blue earlier. If there is dynamics in the disease, the kappa light chain or the heavy chain IgG, IgM, or IgA is progressing every time you go to the doctor, maybe daratumumab is for you, and it's always worth bringing this up and discussing the data with your provider so they can direct you in the right direction. Okay, multiple myeloma, we probably have heard of slim crab. If a patient had MGUS or smoldering multiple myeloma, now they're having some worsening anemia, which is the hemoglobin going down, or the calcium is going up, or the doctor is now concerned about their kidney function, or they're having local bony pain, and they're getting imaging, and there's something called lytic bone lesion on their imaging. That's really the time to do more evaluation to see if there's really a diagnosis of myeloma. We can diagnose myeloma either with the SLIM or the CRAB criteria, and it's listed here. I don't think I have to go through everything, but greater than 60% plasma cells in the marrow, or that kappa or lambda ratio or lambda kappa ratio of above 100, or multiple lytic lesions on the scan will diagnose multiple myeloma. The CRAB criteria is when there's 10% plasma cells plus calcium above 11, or creatinine above 2, which is a reflection of the kidney function, or just worsening anemia or hemoglobin less than 10, or bony lesions. As long as there's that 10% plasma cells, myeloma can be diagnosed. Now, there are several drugs that are out there, which is very good. If one doesn't work, there's always another thing that we can try in myeloma right now. So it's a very hopeful space, and more drugs are being studied, more drugs are being approved. So this list will only grow up, and we will only have more options to treat multiple myeloma. So very exciting. The myeloma treatment paradigm in general, if a person is stem cell transplant eligible, which I won't go into that, but basically, we would treat patients with 4 drugs at the beginning, get rid of as much of the myeloma cells as possible. And to maintain that remission, to consolidate it, we give high-dose chemotherapy with melphalan if they are eligible or if they are willing to do that. And some patients might not be eligible. In that case, we would do more cycles. If we're doing 4 to 6 for induction, we would be doing 8 to 12 of the same drug for induction and consolidation if we're not doing high-dose chemotherapy here. And then the next thing will be maintenance, usually 2-agent maintenance, 2-drug maintenance as the common one that we use right now based off of available data. Patients would be on lenalidomide if they tolerated that okay, and can be on it. And daratumumab would be the second addition in most cases nowadays. Now, if you had transplant long time ago, or if you are just on single agent lenalidomide or Revlimid, or if you're on combination Revlimid and PI, there's nothing wrong with that. That was what we used to do a couple years ago. We're now adding a second drug on the maintenance setting to prolong remission because some studies have shown advantage of adding that second agent in prolonging remission. And we have, cell-to-cell or Carvykti that Dr. Brandon was presenting about at Relapse. We have ide-cel, we have bispecific antibodies, we have selinexor, but always here too, if there is a clinical trial is your way to have access to those drugs that we know are working, but are not approved yet, are not available yet in that setting. So that's your opportunity to get those drugs. So definitely jump on that clinical trial train. Any cancer study, it is now being done in comparison to what is known to work. There is no clinical trial in cancer that will compare observation, for example, because no, we cannot observe, we have to treat. So it will be comparing one drug to another. And most often it might just be one arm, which is you will be getting all the clinical trial drug as long as you enroll on it. There might not be randomization into another group. But anyways, for every clinical trial, the principal investigator, your doctor, should be talking to you, and you have to make sure you understand everything, the number of visits it takes to the institution you're getting the clinical trial at. So that those are all the things that you need to be considering and be aware of when you commit. And also asking about what are the assistance available? Can you pay for gas if I come, or if I have to have extra night at the hospital or at the hotel, will there be reimbursement? Those are things to ask for as long as it allows you to stay on that clinical trial, one, to get the benefit for yourself and have access to those drugs that are not available in standard of care. And number two, to help the research and improve treatment for the next person getting diagnosed with myeloma. So clinical trials, just prioritize them all the time and don't forget about them. I'm just going to reiterate couple points here that Dr. Blue already mentioned. That is, after the FDA, actually some researchers from the FDA did study and find out that there were 10,157 patients on clinical trials that led to the approval of drug in multiple myeloma. And only 4% of those patients, those 10,000 patients, were African American or Hispanic. So what that means is that the drug is being developed and we are not having a good understanding of the efficacy of the drug in that population or the side effects that are unique to that population. So we basically depend on what is called real world data, which means the drug is available, we're giving it in the hospital, and we're looking back at those patients and see, did it work for them? What side effects did they have? How does it compare with the rest of the population? But it just tells us that we need to do better in terms of participation. The other study here is just telling us that 85.3% of trials did not have a Black population that closely mirrored their makeup of the US population. I'm not telling you this to discourage you, but I'm trying to motivate you to take part in clinical trials next time. All right. Even though, we really did not take part on most of these clinical studies, there was report of improved outcomes among African American patients with multiple myeloma with equal access to care. So they looked at patients that got treatment in the VA, where you don't have to deal with private insurance approving this and that, and where everyone can get pretty much similar standardized therapy. And median overall survival was 5 years for African Americans and 4.5 years for white veterans in this study. And age at diagnosis had substantial impact on overall survival, just like how we have been saying the African American patients are diagnosed at an early age than the rest of the population. So this makes you wonder whether there a socioeconomic factor or is this just disease biology? At least this study seems to favor having equal access to multiple myeloma drugs would improve outcome for Black multiple myeloma patients. The other study done also reflected the same thing. They looked at the SEER database and linked it to the Medicare data, and they found out that multiple myeloma patients um, of African ancestry or African Americans and Hispanic patients got autologous stem cell transplant and other available novel treatment for multiple myeloma months later than their white counterparts. But still, African Americans have the longest multiple myeloma specific survival on the study that was reported in 2019. How about the other drugs? We're talking about all this new developments, all these drugs that are coming up. This is a study that was done. The physicians were asked what is available for them to give to patients. And from monitoring, from side effects standpoint, what do they think about all the agents that are available? And basically, you can see that CAR-T is the list available. Teclistamab is the bispecific antibody included on this survey. You can see that it's also not widely available to these physicians to give to their patients. And, physicians, depending on their settings, in the setting, like whether they're working in the academic institution or outside, they did have different comfort levels regarding the side effects of these drugs, the financial burden, lack of drug education, logistics. So, the physicians answered there is really significant amount of concern. For example, if you take this CAR-T, ide-cel, they were concerned about the financial burden, the financial toxicity, the same with selinexor, teclistamab. So there is significant limitation that still needs to be addressed, but as patients, what we can do for MGUS, improving our lifestyle, our diet, for smoldering multiple myeloma, knowing that there's treatment option, and at level of multiple myeloma, if there's clinical trial, taking part in that, and will eventually, hopefully, lead to a better outcome. And my conclusion here is access to healthcare is a function of several interdependent factors, and access to multiple myeloma care is limited, and there exists significant disparity among different patient populations. Future clinical trials, this is for us, in multiple myeloma should be patient-centered and should focus on different domains of access to promote optimal healthcare outcomes, and it should always be patient-centered to result on all the rest of the things. And thank you. That concludes my study, and I really apologize if I overloaded you with all this information, but I'll be happy to take any questions here.
Awesome. Thank you for the awesome presentation, Dr. Multiple. Um, I know we're running low on time, but I want to make sure that we have time for some questions there. And I wanted to start it out. So we know that, patients are wanting to participate in trials more now than I think they ever have. But there's still a lot going on to where they are still excluded from trials. How do you address that? We think about clinical trial design, and I know there have been lots of improvements, but we're still just not there yet. What is being done when it comes to trial design that would make it to where more patients, African American patients could participate in clinical research?
Yeah, that's an excellent question. We are trying to make clinical trials as patient-centered as possible. When it comes to allowing the clinical trial to be close to home as much as possible, trying to take them to remote sites where, the community is at, instead of trying to limit it to our own centers. That's one. The other thing is what potentially can affect African Americans is the white cell count. And we know that, due to the genetic change, African Americans can have a lower white blood cell count. So, reestablishing what is normal for the Black population versus what's normal for white patients. So trying to redefine those numbers. So we're not just simply excluding patients because of their numbers are not A, B, or C. So making it flexible in that direction is also another thing that we're trying to do. Just flexible hemoglobin. We used to say no, if you get transfused within this amount of time, even though your hemoglobin is higher, you cannot be a part, but allowing transfusions as long as it's within reasonable time range from being admitted to the clinical trial. So, and also some drug companies now, they assist with transportation mileage. We don't want that money to be too much where the patient is being forced or is doing it for the little benefits, but just to allow them to assist them. So being mindful of their situation and helping out with gas, for example, so they can drive to the hospital. So taking those things into consideration are some of the few things that we're trying to address on our side. And also taking the time to tell the patients about the clinical trials available. I feel like more than the patients who go through screening and fail because of screening, I think the patients who do not get to hear about the clinical trials might be what's driving this disparity. We have had clinical trials before in majority Black patients when I was doing my residency at Meharry Medical College, and we were successful in recruiting patients. I think so. There is definitely appetite from the patient side. If there's a little bit of education and telling them this is how it's going to benefit you, this is how it's going to benefit us, and this is how it's going to benefit the patients coming or getting this diagnosis after you. Yeah, so I have had good success when it comes to discussing that, taking that time. So that's another important piece that might be missing.
Yeah. I'm so glad you mentioned that. It's education. I think the more we know, the better we can make those informed decisions and not just go along with what's been happening.
Mhm.
Did anyone else have a question? I don't see any hands raised. Let me just check the box here, see if there's any other questions coming. Okay. All right. So I know we're pushing time, but I do thank you, Dr. Biltabo, for being here. And if you could just hang with us, we may have some more questions. But I do want to, turn the floor over. We do have a patient that's going to be speaking or sharing a little bit about her experience. With these novel therapies that's going on, it's really the patient that's experiencing everything. So we really wanted to hear what's behind this from somebody who is, kind of been there. So I want to talk with Joan. Joan, and I don't want to cut you short at all because I definitely want to get your experience out here. Maybe Joan, you can just tell us a little bit about, you've been through several of the novel therapies. So, the earlier lines, you've experienced CAR T, experienced the bispecific. I think you're on a bispecific now. When did these therapies first become part of your care? We'll start with, say, the CAR T. When did you first experience with the CAR T? Because I think it was probably in that trial setting at the time.
So thank you. It wasn't, I did not, right? But it was close to the ending of the trial, so I did not be a part of the trial. I did have it in 2022.
And tell us a little bit about, I mean, how did that come up? Had you done research on it, or did the doctor kind of present that to you and you kind of did some research to say, yeah, I want to do this? Or, how did it unfold for you?
Prior to prior to the vaccine, I was in a clinical trial for a couple of years, smuggling of the immunization. And so I always, because I have been involved in the medical world 7 years, I always look to see what's next, what's coming. I was in the presently not on my list, I was not to know what am I going to do in the year. And so the doctor that I had at the time, and I had had for many years, and she was wonderful. And she said to me, you know, when you stop food, should be 15. And she said, I knew about two specialists. She said, I'm going to become a great about it. All of my doctors have been medical specialists, specialists, and does the whole entire journey. And she said, I'm going to turn you over to a different, you know, it's all about, and you're going to treat on the waiting list, because at that time, there was a waiting list that people to get.
And you know, as you think about it, Joan, I think you were treated at a teaching institution, so it's probably a little different there. But what was that process for you? You know, getting referred, you're getting approved, and things of that nature. Can you share with us a little bit about maybe some of the travel logistics or coordination of care that you experienced?
So I have been treated after being doctor of Boston, Belgium since 2003. And so I don't live far from it at all. I'm very fortunate that I'm my family and south, so it was really easy for me to get appointments. I had I had caregiver that used to go to and it's good for you know, so I mean, everything isn't a caregiver, so it was really easy for me. So we had to find a spot that was for that when they wanted to the probably the treatment and the disease wasn't too big or too small, but they now to give you self the disease wasn't expected because it's not going to everything still. So there was a little bit of a dynamics that happened because I wasn't in treatment. And so the kind of was waiting for me to get worse and worse. And so I started to have normal, so we did a little bit of bigger medication. It was just giving me some drugs to get me over. And I also had some radiation to help me deal with the pain that I was having,
Mhm.
having, and we just waited a little bit. It wasn't long, and I didn't have to, you know, it wasn't mean I couldn't get it. And so it wasn't long in the waiting, and then we just started the questions process, with the similar to, you know, stem cells and prior to the stem cell treatment, I had gotten stem cells collected and we were just sitting there. We decided to first step and not take the second step because I had a bigger disease burden and you know, having a disease in seconds. So we took the T cells, they took the T cell out and we had them from out and then we had to cut that. The smallest bag I've ever seen was empty. And I was in the hospital and they did the patient, but I was in the hospital and receiving cells that and if it gets you time, and if it's going to what kind of female where you people that jobs and thank them and you know they do got movement. And at this time it's 2022, they weren't. And so when we did have the CRS around them, they were giving flags to help me the process and it wasn't easy to go I'm very young. And fortunately for me now, I truly lasted about 8 weeks. And
Wow.
and
Wow.
that's something else. And I will now to customer, which is a fight in a style time. Almost 3 years ago, in September of 3 years. And this is the first time in the gym, drug has kept it, I call it the beast. The drug has helped beast to sleep. And yet, but it's not interfering with life, but it's been purposely dictated and going to do. And I'm going to love you, getting busting up the rest of them. And off I go. I do feel, and I do because please, customer, there was like access and so I think that I need to make and I've also put some other and happy that he's another the man he was and also I want to do this since 5 2. So that's from 2022 to present. And so right now, I kind of feel like, even though I'm done,
Joan, give me 1 second. I wasn't watching the chat. So apparently everybody can't hear you. They're having a hard time understanding you. I'm sorry. I heard you there, but yeah, maybe check your mic there. She says, unfortunately, can't hear you, but I'm sure you're sharing some good stuff. Yes, she is sharing some good stuff there.
now,
Um,
better,
is that better? You guys can give a thumbs up or something in the box there, or
that better. We're going to anybody tell us it got better.
okay, I
Okay.
see one thumb up there.
I
Yeah.
think I need to be closer to my mic.
Yeah.
So I don't know how far back people
But
didn't hear
no,
me.
one thing that you said, and I want Dr. Biltabo if she could maybe respond or let us know on this. So you said that you had that CAR T and it lasted 8 weeks.
8
Now I
months.
know eight
8 months.
eight months. Okay. So I know Dr. Blue was talking about, it could be a one and done. Obviously, that was not your case there. Dr. Biltabo, could you speak on, how often does that happen? How often do we see individuals that do have the CAR T therapy, relapse after 8 months, or that just seems like a short period of time? How often do you see that? Is that common?
Yeah, that's a very good question. Yes, we sell this CAR T as one and done. It could be one and done for some patients, but there are two CAR Ts that are approved right now. Abecma is one of it, and Carvykti is one of it. I am one of the ones who are having difficulty listening to Joanne, so I don't know if you got which one, or if it's just not either one, which is possible on a clinical trial or whatnot. But the median duration of a progression-free survival for ide-cel is actually around 8 months. So it's consistent. And in responders, its duration of response is around 11 to 12 months, which is around 1 year. Whereas for Carvykti, median duration of response is around 30 months. So in patients in whom it works, we have to still remember that unfortunately, there are some patients it doesn't work greatly in. What we're learning is the more we push out CAR T, and also if we use another BCMA targeting, which is like teclistamab, for example, because both of them work on the same target, if we use it right before using the CAR T, then it can affect the efficacy of the CAR T. So if any patient has access to CAR T, CAR T should be prioritized. And this is supported by the International Myeloma Working Group recommendation as well. If someone has access to CAR T, do it in the earlier lines, do it early rather than waiting, until we're several, lines out. Of course, some of us, you might have been diagnosed several years ago and have had several therapy, prior to CAR T, which is completely fine. Again, in that setting, instead of doing a bispecific, if there's an opportunity, do the CAR T first, because CAR Ts work better in that setting, not in the reverse order. So 8 months of progression-free survival is definitely not out of what we expect, depending on what CAR T was used, and also depending on what line of therapy it was, what drugs were preceded the CAR T itself. So there are several different factors that determine how long of a response the patient can have. But on the original CARTITUDE study, if I may add, around 33% of those 97 patients on CARTITUDE 1, 5 years out, and 33%, while two-thirds progressed, 33% are still in remission. So there is a hope to finish it on a hopeful note. So still, if you can get CAR T as early as possible on your line of therapy.
Yeah, thank you. Thank you for sharing that. And I know that we are over time. Thank you to everyone who's hanging with us. But I want to give the audience an opportunity. A lot of times, you never get to talk with someone who's experienced these therapies. So I just wanted to put it out there. If you have questions for Joan or, Dr. Biltabo that we haven't addressed here, now is a perfect opportunity to drop it in the chat or just raise your hand and ask those questions. I know for me, if I had never been through any of this, I would want to talk to a patient who's experienced it there's nothing like firsthand experience to really get a better understanding of that. Um, so there's how long do they allow the body to rest between treatments? A participant has that question there. Dr. Biltabo, maybe you could take that question.
Yes. So, it depends what the disease is doing, unfortunately. We don't dictate how long we can stay between therapy. Sometimes when you see the patient, you are like, oh my God, you should have started treatment yesterday. So we're trying to jump on treatment right away. It depends on what that relapse looks like. If we can buy time, give them a little bit of bridging therapy, then CAR T would be ideal still. Once they progress after CAR T, again, it depends on the type of progression. If someone is coming in full-blown myeloma where their kidney function or their serum calcium is affected, you just have to do something about it right away. So, as soon as you can, is really when you would give the next line of therapy.
Gotcha. Gotcha. I'm just curious, is anybody here on the call considering CAR T or had CAR T, considering this treatment? And you're comfortable just raising your hand or just drop it in the chat, give us a thumbs up in the chat or something like that. Just curious, you don't have to. Um, but Joan, I want you to kind of briefly talk about you're on the bispecific therapy now, and we heard some of those side effects that Dr. Cole mentioned. What has your experience been, having been through several lines of therapy? What is your experience? Where are you now? Give us an update on the latest of where you are now.
So, first of all, let me apologize. The sun is making me look like I have a mustache there. I feel like I drank the milk. Can anyone hear me
Is,
better?
can everybody hear Joan now? It's better. Okay.
Better,
Okay.
better. Okay. So and yeah, I am on to custom and just to piggyback off what the doctor said, I had a Becky back in 2022, and the thing is that we didn't know if we should have part two before the fight or the fight before the part two back then. It was just kind of random, but I things in my life don't happen randomly. So because we were praying about different treatment options for me and just praying about my journey. It was that I got the CAR T first, and now I'm on to Tepestamab. And Tepestamab, I believe in myself. And let me make a disclosure. My myeloma is my myeloma, and your myeloma is your myeloma. And I like to say that because what I say is just my experience and my journey. What works for me may not work for you. You could have the same genetics, you could have the same profile as a multiple myeloma patient, and it still be so different in our experiences. So I always say, take what I say as a grain of salt. But my experience with Tepestamab was really tough. I was inpatient. I mean, they do it outpatient, but I was inpatient and I experienced a lot of side effects. And once I got out of the hospital, I had some lingering side effects of the drug. It took about 6 months for it to straighten out in my body, and the body got used to it. And now it's just every other week, and it's going to be 3 years in September. And so, like I said before, people may not have heard me, but this is the first time since I started on the journey that a drug has kept the beast asleep. How long he's asleep, one never knows in our body. But right now, and I tell you today as today, he's asleep. And so I go in every other week when I get my treatment. And I was saying before that I still get tomato, which is the bone spectrum drug, and I still IV EEG, and I have been getting that since part two. because of the way it affects white blood cells. And that IVIG just boosts my white blood cells. So I do get that on a regular basis.
Okay. Okay. And it sounds like this has become part of your new normal. I always use that term, but it's just how you're living your life now. That's part of how often do you go in for your treatment?
Every other week. I
Every
try. So it started off as weekly, and now it's every other week. I tried to find out if I could do it monthly, and I was told, monthly is for people who catch a lot of infections, but because it's not working, let's not try to fix it.
Gotcha. Gotcha. Awesome. Awesome. Thank you for sharing, Joan. Thank you for being here. And I know we didn't get through everything, but I do appreciate you coming and sharing your story. And Joan's always available. Joan's a coach. You can reach out to her, on the platform, on the HealthTree platform, and talk to her one-on-one. Phyllis, okay, I thought I saw a hand up there. Phyllis, we'll do Phyllis' question and then we will wrap things up. And I do appreciate you all hanging with us this afternoon. It's a great session today, so thank you. You're muted, Phyllis. Unmute.
Okay. Am I unmuted?
Yes, ma'am, we can hear you.
Okay. I just wanted to share my experience. I was offered a clinical trial for CAR T, but I refused it because I just didn't think that was for me. But I do want to share I had a good outcome with the teclistamab. I started in August of 2025. I was 90% covered with plasma cells in my bone marrow. I was told on the 27th of January by my doctor I had a complete response. I am MRD negative. And I go once a month now for my infusion. And I just want to share with everybody just, keep the faith and hang in there and, just be positive.
Yeah.
Thank you.
Thank you for those encouraging words, Phyllis, and congratulations on where you are right now. That's awesome. That's awesome. Um, Dr. Biltabo, you still with us? Would you have any closing words before we shut out here this afternoon? Thank you so much for being with us.
Absolutely. Yeah, I'm glad to hear Phyllis's story and Joanne's. Yeah, everyone's myeloma is different, and I couldn't agree more. Everyone's is different, so don't try to compare your journey with the other person. The name is the same. We might all call it myeloma, but everyone's genetic alteration trajectory path is different. And the good thing about myeloma right now, it's a very hopeful space. We can give another treatment if one fails. So it's always good that we have some more tools. And don't forget that clinical trials are always an opportunity for you to get, state-of-the-art treatment before it's available on the market. So consider them and be a part when you can. That will be it. Thank you so much for having me.
Absolutely. And we welcome you. I don't think you were here when we said it. I know this is your first time being with us, but I hope it's the first of many. We welcome you to this community and I will definitely be in touch with you. So thank you for
Thank
joining.
you. I appreciate that. Thank you.
And thank you all for hanging in there. I know we are over today, but it's such a good conversation. I just did not want to cut it off there. But I do want to let you know of a few other upcoming events that you may be interested in. Later today, 7 p.m. Eastern, there's going to be another webinar. It's called Unshaken, Navigating Blood Cancer with Jason Mook. I hope that's right. On tomorrow, Friday at 2 p.m., HealthTree is going to be hosting another gathered community event. And this is going to be caregiving for others while navigating your own blood cancer diagnosis. So that's interesting. And then I invite you to join us back here next month. Next month, we will welcome Nia Bailey. She's the president of the Bird Cancer Education and Advocacy Foundation. And she's going to be talking about innovation in our DNA. So you don't want to miss that one. Registration for that is going to open pretty soon. So I hope to see you back here next month with us. Again, I want to thank our sponsors, Pfizer, Johnson & Johnson, and Kite. And then thank you for helping us create this strong Black health community. If you have questions or you need anything, my email address is there on the screen. Don't hesitate to reach out to me and enjoy the rest of your day. I hope it's warm where you are. If it's not, bundle up and stay warm. And we'll see you guys on a future webinar, hopefully.